So this session has been put together with great enthusiasm by the Department of Family Medicine and the Department of Pain Medicine and Palliative Care. I'm Russ Portenoy. I chair the Department of Pain Medicine and Palliative Care, and we put this joint session together with recognition that it's just past July 1st to bring together new people to the institution and some of the key faculty and talk about some administrative issues, do some meeting and greeting, and then also provide some interesting and very important didactics, which will be offered to you by yours truly. So the goal this morning has three parts to it. The first part is that I'm going to give you a formal lecture, probably about 30 minutes in duration, focused on issues related to safe prescribing of opioid drugs. That's a topic of such incredible import right now in the United States because of the rising problem of prescription drug abuse, new regulatory initiatives by the state and by the federal government, and the concern that clinicians have about safety of their patients and prescribing in a regulated environment. Very, very critical issue for family medicine docs on the front line and for pain and palliative medicine specialists who are seeing the challenging patients on referral. After I finish, we'll do a bit of introductions, and then we're going to discuss the approaches that are being developed or proposed by the respective departmental leaderships to have cross coverage of our patients linked to the opportunity to learn. And then finally, we'll talk about a novel approach that we wanted to try to implement for the first time this year called the buddy system. So this is a very dynamic time for the two departments working together. We're trying to do some very creative programming. The chair of family medicine and I totally committed to making this work out over the course of years. This is a process, so you are all our pilot in some ways. And so what we hope to happen in this lecture and as we go forward with joint activities is to see what works, what doesn't work, and how we can continue to improve things so we work together to the best interest of the patients and to the respective training programs. So I am not going to lecture from that, but I'm going to lecture from that. So the first part of today is to talk about safe opioid prescribing, and particularly with reference to a regulated environment. And as I started to say before, this topic has taken on very great importance in the United States. Personally, I've been teaching opioid pharmacotherapy since the early 1980s, and there has been an extraordinary transformation in what the key clinical messages are about how to manage patients who may be appropriate for opioid drugs on a long-term basis. These messages are being generated by the clinical community, by the regulatory and law enforcement community. There's a great deal of controversy going on. You will undoubtedly see reports in the media and also reports from the regulatory agencies that monitor prescribing that you'll be worried about, that you'll view as perhaps putting yourselves or your colleagues at risk. And it's incredibly important as you go forward, even those of you who are starting the training program, as you go forward and you see patients in the office or in the hospital with moderate to severe pain, and parenthetically, pain is the most common reason patients come to physicians' offices in primary care. So as you see those patients and you begin to do some critical thinking about how do I position opioid therapy among the various things that I can do with patients, and then how do I select patients for long-term therapy, and then how do I provide therapy over the long term in a way that's safe and effective, the key messages that have been developed are the ones that you now have to incorporate and begin to apply. And that means both in terms of the decisions in real time, and it also means in terms of your documentation. I can be very reassuring still in 2011 that if you incorporate the key messages about safe prescribing and you document appropriately, issues about your relationship with the regulatory and law enforcement community should not bring you much concern. In fact, just 2 weeks ago, I had a neat opportunity to lecture to the physicians who work on the medical board of New York State. And by and large, the scary part is, as you can imagine, they're mostly retired surgeons who know nothing about pain or pharmacotherapy. The good news is that they know nothing, and they know that this is an evolving issue, and they're desperate to do it right. They're desperate not to inappropriately investigate. They're desperate not to keep patients from having access to these drugs when they're the right drugs for them. And they're very willing to cut doctors slack if they see the documentation. Their number one issue with me is, or their number one question, which was rhetorical, is how come doctors don't document? So let's talk a little bit about the issues here. I'm going to talk about the role of opioid therapy generally, risk management during opioid therapy for pain, and a couple of other issues. I want you to recognize that in 2011, the international consensus continues that opioids are the mainstay drugs for acute, moderate, severe pain, and also for chronic pain related to active cancer or other advanced illnesses. This is the international consensus. You can argue about whether there is an evidence base for this. It's not relevant to practice. This is what every professional society around the world has endorsed, and that is that opioids are to be considered the first-line drugs for these two populations. Long-term opioid therapy for so-called non-cancer pain is where the controversy is. Pain specialists agree still, almost uniformly, that long-term opioid therapy is safe and effective for some patients. So most patients with chronic pain related to active cancer or other advanced illness, and some patients, a far smaller proportion of patients with non-cancer chronic pain. That's what pain specialists agree is appropriate. But we now recognize, as in 2011, in contrast to the way this was discussed 15, 20 years ago, that the risks are very significant and they must be understood and managed. There is no consensus around the world about how to position therapy, meaning to say where among the enormous number and complexity of pain management strategies you can choose for a patient, pharmacotherapy and others, how you should position long-term therapy. And there's also no consensus about who should get it, and there's no consensus about how it should be done safely. So that's a problem, right? We have evidence-based guidelines, but they're all based on weak evidence, and many people have already rejected them. So it's a problem. It's very important, however, that you have some strategies for taking care of patients. The patients show up. And I know very well from my colleagues in family medicine that sometimes it's the most challenging patients that end up in family medicine, in primary care, because that's the last stopping point. You know, they've been rejected by specialists all over the place, and they're there at primary care, and they say, I can't function because my pain is severe. Help me. So this is the challenge. They are there, and so you have to have a clinical strategy. So the clinical strategy that's appropriate is based on the concept that every patient gets assessed. If you can identify an etiology of the pain, you consider primary disease-modifying therapy. Every patient gets assessed in terms of factors that may be contributing to disability and suffering and impairment of quality of life. And the symptomatic therapies in the plan of care might be to address pain as well as these comorbidities. And as you develop the plan of care for pain, recognize that pharmacotherapy is only one strategy among many other approaches, dozens and dozens of approaches. And opioid pharmacotherapy is only one type of pharmacotherapy among the potential use of dozens and dozens of drugs. And so the critical thinking here is to decide who should get a trial of opioid therapy, how to implement it, and how to make the decision whether or not long-term therapy should be continued. So what's the nature of the evidence by which we would develop these guidelines? Well, the good news is that there are many RCTs and systematic reviews. There have been 6 systematic reviews of opioid therapy for long-term for persistent pain in the last 5 years. That's the good news, literature. The bad news is that they all disagree with each other. And it just goes to show you can systematically review a literature, and what you get out depends on what you put in and how you spin the data once it's in the statistical plan. So the bottom line is we have many systematic reviews. They yield mixed findings, and they provide little help in developing evidence-based therapy. If I had a couple of hours this morning, I would share with you the specific results of the systematic reviews, because that's the nature of the evidence. In the absence of time, I'm just going to give you the conclusions. They basically fall into 2 camps. There are systematic reviews like this one that was published in 2006 that concluded there is short-term efficacy for pain and function in all types of pain, short-term. So all of the efficacy studies are short-term. Opioids are better than other drugs for pain, but there is no evidence that they're better for functional outcomes. And there are insufficient data to judge long-term outcomes. So that's a positive one. At least it says opioids work. Here's a negative one that gets cited by many people who have a big problem with pain, with opioid therapy. This was published in the Annals of Internal Medicine in 2007. It focused solely on people with back pain, and it concluded that opioids have limited, if any, short-term value in chronic low back pain. Evidence about substance abuse is too limited to draw any conclusions, and there are insufficient data to judge long-term outcomes. So some systematic reviews show you the evidence that they review and conclude opioids seem to work in the short term. We don't have any data to judge long-term effectiveness. Some systematic reviews look at the same studies and they say, we don't have any evidence that this works. In fact, a large managed care company in Florida just refused to pay for all long-term opioid therapy on the grounds that there's no evidence it works. That's what happens when people misuse data, right? I mean, as clinicians, just realize that. We exist in a web of people doing the wrong thing for all of the wrong reasons. In the Journal of Pain and Symptom Management, there was a systematic review done just of surveys. Surveys, very interesting, because obviously most systematic reviews focus on RCTs. This one focused on surveys. The conclusion was many patients stop therapy. Very important. I mean, I could have told you that from clinical experience, but it doesn't really jump out at you from the literature. But with this systematic review, it made it clear that many patients who are given the option of opioid therapy don't want it. They stop therapy. But there is weak evidence that those who continue have pain relief over time, and there are insufficient data to judge other long-term outcomes, including function and drug abuse. So what's the end result of all of the systematic reviews? The RTCs suggest efficacy, but short-term efficacy has little relevance to long-term therapy. So all of that evidence is not useful to you as you try to make a decision about putting people on opioids for periods that can extend to years. Observational studies provide weak evidence that many patients stop therapy due to side effects or poor response, but there is weak evidence as well that there is a subpopulation of patients with persistent pain who gain ongoing benefit. Parenthetically, that's what people like myself have been saying for decades. Not that everybody should get opioids, not that everybody with opioid therapy does well, but that there is a subpopulation of ill-defined number, of ill-defined proportion, who do well. And sometimes they need high doses, and sometimes they need complex regimens. That's our observation. That's what pain specialists believe. Other outcomes, including those related to risk, are poorly characterized. That's bottom line from the literature. So we don't really have much evidence, and despite the lack of evidence, in an era of increasing concerns about risk, clinicians came together under the auspices of the American Pain Society and the American Society of Pain Medicine and tried to create evidence-based guidelines using very, very rigorous methodology. And the guidelines were published in 2009, and they frankly have been a bit controversial. They are, the overwhelming majority, something like 90% of the individual recommendations are based on weak evidence. And the basing of a guideline on weak evidence is cause for some to say that it just shouldn't be believed, even though the process of guideline development includes vetting of a potential guideline by an expert committee, which is interdisciplinary and has different points of view. So as you may know, the development of an evidence-based guideline includes an evaluation of the level of evidence and then something called the grade of recommendation. And the grade of recommendation is based on the level of evidence then analyzed by an expert committee. And almost all of the guidelines in the American Pain Society guidelines are based on weak evidence because that's all we have, but it's a high level of recommendation, a strong level of recommendation because the committee felt strongly that these guidelines are justifiable based on experience. But having said that, the lack of evidence, as I said before, is cause for some people to reject it. So the guidelines have actually been fairly controversial. What do the guidelines say? The guidelines say that it's reasonable to consider an opioid trial for all patients with severe pain, But you need to do a case-by-case analysis based on what conventional practice is. Are there reasonable alternatives to this therapy? Is the patient high risk for adverse effects? And is the patient likely to be a responsible drug taker? I emphasize the word trial here. One of the things that the guidelines said very strongly is that you should not fall into long-term opioid therapy. As someone who has fallen into many things in life, including long-term opioid therapy, I tell you the risk is very high. That you see a patient, and you start a patient on Vicodin or Percocet or Ultram, and before you know it, the patient has come back for 4 appointments, a year has gone by, they're still on opioid therapy. By then maybe you've said, okay, let's switch you, you're already on Percocet, you're taking it 4 times a day, I'll switch you to OxyContin. And before you know, you've fallen into long-term commitment with a long-acting drug. The American Pain Society, American Academy of Pain Medicine guidelines strongly emphasize that that's a dangerous way of doing things. The better way of doing things is to do whatever you want in the acute situation that you think is medically appropriate. But if the thought comes to mind that it looks like this therapy is going to be long-term for you, then you take a step back and you say, have we actually done this in the context of a therapeutic trial in which I've explained to you the risks and benefits of long-term therapy? We've initiated therapy, we've titrated the dose, we've treated side effects, and we've monitored your behavior long enough to know whether or not there should be continued. Do you have the appropriate, you patient, do you have the appropriate expectations about what I expect you to do in terms of following instructions and what will happen if you do not? That's the nature of a trial, where you explain it all up front, observe the outcome, and then make a decision. And what the American Pain Society guidelines say is you can do that at any point in the therapy. You've been treating somebody with Vicodin for a year, time to do a trial of long-term opioid therapy. That's a very, I think, very innovative concept that came out of that process and is buried in one of the guidelines. The critics don't actually focus on something as creative as that. They focus on the fact that there's no evidence that it works, so why are you giving people guidelines? Bad news. But the bottom line is that this is a very important point. Okay, so we have guidelines, and you can look them up if you want them emailed to you. Feel free to send me an email. I mean, they're on the web. You just look up American Pain Society, evidence-based guidelines for opioid therapy. You can download the PDF. You can take a look at it. It's probably a good background. But the question here is, if you're going to do a trial and consider long-term opioid therapy, what are the factors you have to consider? And one of the factors you have to consider is that in 2011, there is a great concern about rising rates of prescription drug abuse. And let me just show you why we have such concern. There are trends over 2 decades, a rapid increase in opioid use by pain specialists and primary care physicians. So opioid use has risen by many fold over the past 15 years. There's also been a rapid increase in adverse outcomes, including abuse and unintentional overdose, leading to mortality. And as a result of that, there is a rapidly evolving response by both the clinical community, including the fact that I'm here lecturing to you, and I never did that before, and the regulatory and law enforcement communities. These are data from DAWN and the National Household Survey of Drug Abuse that is done by SAMHSA, a federal agency, and these are the rates these are 2 separate metrics that both suggest abuse, and these are the rates of rising abuse of prescription drugs from the mid-1990s to the early 2000s. I could pull out a later slide on this, and the numbers are even higher. This is data from 2006 showing that opioid drugs in this year became the first drug abused by new initiates into substance abuse. Since that time, there have been sort of a contest between marijuana and prescription drugs about which one is abused first. This is young people going to their first party as 13-year-olds and thinking that they're going to get to play spin the bottle and abuse drugs. And the question is, are they going to smoke grass, pot, I don't know, whatever you guys call it. Are they going to smoke cannabis, or are they going to pop a pill? And so there's a big context, varies around the country, but the bottom line is that this has increased. This is this slide you'll see all over the internet. This slide is terrifying to parents. The interesting thing is that most of the abuse of opioids comes from people who are taking the drugs from friends or relatives. This has raised a huge issue, for example, in the hospice world, because hospice patients have enormous quantities of Schedule II drugs that exist in the home after the patient dies. This has also raised the issue called the grandma effect, which is who's telling grandma to watch your medicine cabinet when your grandson comes over for a visit? Is that part of routine clinical practice? Is that a best practice in family medicine, to educate patients with controlled drugs that you have to be careful about your drugs going missing because your teenage children are going to take them? So this issue, again, never appeared, but then data like this makes it very scary. It doesn't look like most of the abused medication is coming from pharmacy robberies. It's instead coming from you and me. So the bottom line is that management of risk is now considered a package deal. And by package deal, I mean you guys, all of you, myself, who want to take care of people with pain, need to develop competency in opioid pharmacotherapy. But competency in opioid pharmacotherapy forever has focused on techniques to optimize pharmacologic outcomes like analgesia and to minimize side effects like constipation. But now, the new obligation that we all have is to develop competency in techniques to minimize risk. Safe prescribing or risk management, that's no longer something that others do or we just have to refer if there's a problem. Risk management is now what primary care doctors and specialists who don't have a subspecialty in addiction medicine have to do. We have no choice, it's what we have to do. And I can tell you from my experience in lecturing to the medical board docs that they do get that as well. They understand that the obligation is to show in the chart when an allegation is made, because they don't see charts without an allegation. When an allegation is made and they look in the chart, they want to know that that doctor has had control of the therapy and the therapy is being done in a way that's safe. That's what they're looking for. So that's what you have to do. And remember, in terms of the issue of safe prescribing, we have side effects, we have abuse, addiction, diversion, and we have unintentional overdose. So how does the package deal work? I want to propose to you a couple of things that should be now considered routine routine standards for care in opioid pharmacotherapy. The first is the incorporation of a concept called universal precautions. Every patient gets evaluated in terms of safety. Safety in terms of abuse and diversion and addiction and unintentional overdose. Every patient, universal precautions. Compliance monitoring is part of all therapy. Compliance monitoring is not a barrier to a therapeutic relationship. It's a facilitator of a therapeutic relationship. You tell patients, I have to monitor the fact that you're following instructions. I have to verify what you tell me. And if I'm very comfortable that I can do that, then I can act in your best interest. I can be very aggressive in treating your pain with medicines or other techniques if I'm able to always feel comfortable that you're following the instructions exactly. So I have to do things that allow me to verify that. That's why I'm going to check your urine. That's why I need you to bring the pill bottles in. It has nothing to do with trust. I do this with everyone. It's the fact that I can't act in what I hope would be your best interest unless I'm verifying that you're compliant with what I'm telling you. It's just the way it is. And that universal precautions approach opens the door to sort of a standard strategy when you're interacting with patients that doesn't make it personal and certainly doesn't make it punitive. It has nothing to do with trying to punish people for their bad behavior. It has to do with how you act in accordance with a best practice approach to safety during prescribing, right? Okay, so the universal precautions is the key language. It includes compliance monitoring, commensurate with the risk stratum, dealing with problems over time, educating the patient and family about drug storage and sharing, and then understanding how you can be in compliance with laws and regulations. The clinical considerations in risk management include the following, and I'll just bullet this out, and We can give you more information later if you want. I can send you a short chapter that sort of drills down into each of these concepts. If you're interested, just send me an email about that. Patient selection is always based on the assessment. You always tell a patient that you need a trial of long-term therapy before instituting long-term therapy. You always stratify risk. You always structure the therapy commensurate with risk. You always educate patients about the need for adherence and also keeping their prescriptions safe. You always assess appropriate outcomes, including drug-related behavior. You adjust therapy over time, and you always document. These are the key messages. Risk stratification has been done in a variety of ways. This is totally not evidence-based, but it's sort of, I guess you could say it's based on weak evidence. We know that a history of substance abuse, past or current, we know a family history of substance abuse, past or current, and we know that major psychiatric disorders, Axis 1 or Axis 2, we know those three things predict substance abuse in the future. So because we know that from many studies in the addiction literature, those three elements have been used as stratification variables, right? Now you can use a variety of different techniques like validated measures like the KJ8 or the opioid risk tool. The SOAP is the one that's the best validated. There are many others that have been worked on in the last, there are about 12. I could send you a review article on these if you want. Lots of measures. I myself don't have time for measures. I don't use measures. But what I always do is document that I've assessed personal history of substance abuse, including alcohol use, family history, and whether or not there's a major psychiatric disorder. Any one of those three things for me elevates the patient to a higher risk category. And you can, in your own clinical world, you can say high risk, low risk. You can do what Dr. Webster and Gourlay did here, which was high, moderate, and low, not based on any validation data, it's just what they said as clinicians. But at least you have risk strata, low and high. And if a patient is not in the low risk, you must incorporate elements that allow increased compliance monitoring. Now, those of you who have done residencies in addiction medicine, I'm telling you stuff that's sort of a core practice for you, for that discipline, right? This is a core practice for addiction medicine. And all of those things that addiction medicine docs do per routine, we now have to incorporate into primary care, and we now have to incorporate into specialist practice when we're treating pain. And it's basically defining a risk stratum and then choosing techniques for compliance monitoring commensurate with risk. If you have a patient who's a 20-year-old who is, has a history of one admission for detoxification from cocaine and marijuana and is now in a recovery program, but you perceive this person as being fragile, lacking social support, and there's a family history of alcoholism in 5 first-degree and second-degree relatives, you might say, whoa, refer that patient. I can't take that risk. And then that patient may come back to you as a primary care doc. You know that. If that person has moderate to severe pain, you can always say, I'm not going there. But if you think that recovery that person in it is well established enough and actually might be improved upon by giving that patient pain relief, and you want to put that patient on a trial of an opioid, you better incorporate very strict compliance monitoring. That patient should have urine drug screening on a regular basis, frequent visits, prescribing small quantities. You want to avoid short-acting drugs. You want to avoid drugs with high street value like OxyContin, Opana, oxycodone. You want to use one pharmacy. You want to have that person bring the pill bottles in so you can count the pills relative to how much they should have left. These are the kinds of things that should be routine in your practice. These are competencies that I now consider to be core competencies for safe opioid prescribing. Our fellows will learn this, or I will be very disappointed. This is what you need. And parenthetically for our fellows, this is palliative care as well. Because if you think you'll be doing palliative care and you won't be encountering substance abuse issues, I don't know what planet you're on. Okay, I'm going to finish up very quickly, skip this, and just tell you that over the course of time, it's very important to monitor 4 sets of outcomes: analgesia, adverse effects, activities or functionality, and drug-related behavior. This is the famous 4 A's for those of you who have read the pain literature, the famous 4 A's. you're looking at drug-related behavior. You'll get this information from other doctors. You'll get this information from the state, and you should be asking patients. You'll be absolutely amazed with the ability of patients to respond honestly to questions that are very direct. Have you shared your medicine? Have you taken medicine from anyone else? Have you seen other doctors and gotten other scripts? And so if a person is just an aggressively complaining about higher doses, requesting specific drugs, those are all risky. Those are all red flag behaviors, so-called, but they're probably less serious than if you know the patient's selling a drug or forging a prescription. So you have to both assess behaviors and then try to categorize them in terms of how serious they are. This is just a slide showing that behaviors are very common in pain clinics. In a large survey of physicians who work in pain clinics, 50% of patients getting opioids had presented with at least one aberrant drug-related behavior during the past few months. So it's very common. The fellows in our clinic will encounter aberrant drug-related behavior every single week. And the question will be, are you going to manage those appropriately and well, or are you going to ignore that they're there, or are you going to manage them in a way that is difficult to justify, like some clinics around the country do, one strike and you're out? How do you justify that? It's just crazy to me. So these are the kinds of things that are skills that you should learn over time as specialist. My last comment about safe prescribing relates to something very important. And I must tell you that if the law and the regulatory community clamp down on doctors prescribing in a big way during the next 5 years, it will happen as a result of this. Not so much, it will happen as a result of prescription drug abuse too, but the driver will be the fact that caring physicians are killing patients. And the concerns about mortality are very serious and very appropriate. Mortality has been called a new epidemic by the CDC. I really hate the word epidemic in this context. It's extremely emotionally charged. But look up Google epidemic of opioid mortality, and you will see how the word is being used. We have an epidemic of opioid mortality. Notwithstanding the fact that the epidemic of NSAID mortality and the epidemic of mortality due to suicidality in young people given SSRIs is much greater than this, notwithstanding that. But opioids are what they are, and opioid mortality has captured the imagination of some people in the U.S. who think that this has just gone too far. So please be aware this is a real serious issue. We know that the factors related to opioid overdose and mortality are not well understood. Most are polysubstance cases. Most are recreational. But we also know that there are pain patients in here. Methadone for pain significantly contributes to the risk. Methadone mortality itself has gone up more than 300% in the last few years. This is deaths with mention of methadone by intent. So this is unintentional overdose. So this is all types of deaths. This is unintentional overdose here, and this is related to methadone over the course of 1999 to 2003, and it's continued to go up. Why do people die, particularly when they're given centrally acting drugs like opioids, and perhaps particularly with methadone? Some of those deaths probably relate to opioid-induced disordered breathing. This is a specific type of a sleep apnea syndrome caused by an opioid. In one survey that was done, 50% of patients had abnormal polysomnography. This is 50% of patients in a pain clinic had abnormal polysomnography. Now, they had mixed types of sleep apnea syndromes. But a proportion of the patients had this which looks like it's the specific sleep disordered breathing syndrome of opioids. So the bottom line is opioids contribute to sleep apnea. If you have a patient who's morbidly obese, has a short neck, snores, and is fatigued during the day, and you give them methadone and Klonopin and see what happens, you are putting that patient at high risk. Okay, and I'm going to end so we have time. I just want to say one thing about laws and regulations. So, ignorance of the law does not justify failure to follow it. So, You can't be ignorant of the law. We have laws related to opioid prescribing that occur at a federal level, and we have laws that occur at a state level. The state level laws take two forms: the medical practice laws that would lead to the removal of your license to practice, and the laws in the criminal justice system that would lead to your incarceration. If you would like to be incarcerated in federal prison and lose your license, you can break all the laws at the same time. If you would like just to lose your license, you just have to break the medical practice ones. So you need to know something about it. The very important law to know about is called the Controlled Substances Act. Been around since the Nixon era. It basically says that prescribing a Schedule II, this was the law that set up the schedules, right? So Schedule I drugs putatively have no medical use. Marijuana's in there, so you can see how scientifically based that is. Schedule I drugs have no medical use. You can't prescribe a Schedule I drug. That's why medical marijuana cannot be prescribed. Right? Medical marijuana is not a medical therapy, cannot be prescribed. It's illegal to prescribe marijuana, so states that legalize medical marijuana are doing it in a way that says you can get your marijuana for a medical problem, but doctors can't prescribe it because then they go to prison. Anybody live in America here? It's a really interesting country. So it's Schedule I you can't prescribe. Schedule II have high risk of abuse, and all of the drugs we use for long-term opioid therapy, with the exception of drugs like buprenorphine and tramadol and tapentadol, all the drugs like morphine, hydromorphone, oxymorphone, fentanyl, these are all Schedule II drugs. The law says that you can prescribe legally if it's in the course of usual professional practice or for a legitimate medical purpose. And here's something that is really important. If the law is very, very clear that if the physician prescribes and diversion is occurring, that physician is engaging in drug trafficking, and that's a felony. So what our fellows will learn very rapidly in terms of the policies and procedures we follow is if you have a high index of suspicion of diversion, you must stop prescribing. If, on the other hand, the patient is engaging in serious, egregious, aberrant drug-related behavior, but you don't think that diversion is occurring, even the most serious behavior is a medical issue. And you can choose to do whatever you want to do that's medically appropriate with the advice of other people, hopefully. We make decisions as a team sometimes. But the only hard and fast rule is if that egregious behavior includes selling the drug, you have to stop prescribing. That's a felony. We do have a problem, and that is that the medical practice laws in most states like New York basically apply the same criteria as the federal criminal justice statute, right? So when you are asked by the authorities to document that you are engaging in practice that meets these two criteria, if they think that you are not, they actually have the freedom to prosecute you or to try to remove your license through regulatory means. All right, same behaviors can lead to two different things. You hope that the people who are doing this have judgment and are taking the bad doctors who are actually trafficking in drugs out of the system and taking other doctors who might be doing the wrong things because they're duped or they're poorly educated or they're impaired and not prosecuting them. We hope that that happens, but we have no reason to know for sure that that does happen. And you should know that the Food and Drug Administration was given added authority a few years ago, and that authority mandates the development of a risk evaluation and mitigation strategy for long-acting opioids, REMS. After a long time, about 3 months ago, the FDA came out with their REMS for all long-acting drugs. This is a class-wide REMS, first time in history it's been done. Soon they'll be coming out with REMS for rapid-onset fentanyl formulations like Actique and Fentora. And the good news here, and I must tell you, it is really, really good news, is that the FDA did not act in a way that was out of control. The FDA was under incredible pressure from people in Congress and other advocates around the country to enforce REMS with specific regulations that would have been devastating to pain patients. And they heard the pain community, palliative care community saying, don't do that. And they came up with a REMS that mandates education. So you will be hearing about this. You will need to take education to be prescribing, and you will also be dealing with individual companies that are still having individual REMS. Like, for example, a new nasal spray for breakthrough pain just came on the market, just got approved. It's on the market in a few months. It's called Lazenda. That Lazenda prescribing is going to come with an individual REMS that's going to require you to take a little test and send a form into a pharmacy, and that will all disappear when there's a class-wide REMS for the short-acting fentanyl formulations. So at this point in time, we got the class-wide REMS coming into effect for long-acting drugs and a individual REMS for rapid onset formulations of fentanyl, and this is a moving target going forward. And finally, realize that we have state prescription monitoring programs in most states. In New York State, we have a state prescription monitoring program that you can look at online. It doesn't give you real-time information. It doesn't take into account patients who cross the border and get their drugs from Connecticut or New Jersey or Pennsylvania. So it's limited, but you all probably got this notification from the state. I would suggest that you get online, look at it, and to the extent that you ever look at it, just document that you've looked at it, because if anyone ever wants to know whether or not you were concerned about compliance monitoring, documenting that you checked the database for an individual patient is a good thing to have done. Okay, so the bottom line here is opioid drugs are appropriate. According to pain specialists and palliative medicine specialists, opioid drugs are definitely appropriate to consider for long-term therapy in a subset of patients with chronic non-cancer pain. The challenge is to now go forward using a strategy that involves critical thinking when you select a patient, incorporates a trial so that you can actually observe a patient and educate them about what they need to do, and then incorporates universal precautions in every case, with universal precautions being focused on risk stratification, compliance monitoring, monitoring of the 4 A's, and then dealing with problems as they evolve over time. It's a skill set, but I think you'll hear about the same messages in the REMS. I tell you, these messages are all going to be in the REMS required education. So it's good to get started now, but these are the kinds of things that you have to incorporate as a best practice for opioid prescribing as we go forward in the context of drug abuse.